All right, so I got to start somewhat over, but I'm not going to start over. So today we're doing chapter 33, orthopedic injuries, orthopedic trauma. We went over the EMS curriculum, and now we're looking at IVs. And now we're clearing the drawings and we're moving on. All right, any questions about any of that? Torrance is going to be mad at me. We're only on we're only on slide 13. You didn't miss a whole lot, Torrance, I promise. Who else is not here? All right. So the skeleton, we're going to skip over some of this too. We know how that works. We know how all this works. So right here, the acetabulum, where you see this, the ischium, the acetabulum, and all that, where you get your pelvic injuries. All right, that's what ends up slicing open the femoral artery right there a lot of times. Because see how it's held down by the inguinal ligament? So if it breaks at the acetabulum or right here close to the ilium, or right here at the ilium in this weak spot, a lot of times what it does is that crepitus or anything else, it can slice that artery open. So you just got to be careful. All right, typical long bone. They can grow, long bones can grow in such lengths because of the presence of the growth plate or the epiphysis in children. So the epiphysis, you can see that. The epiphysis in kids, you can definitely see it if we'd have had an x-ray of a kid, but you can see it, it's across there, it's the growth plate. And it's what helps, it actually grows from here, all right? And then there's one down here as well. This one's the epiphysis right here, yep. That's why on kids, that's why when we do an IO or we do IOs on people, you're trying to get away from that epiphysis. You do not want to get on that epiphysis, because if you injure or if you scar up the epiphysis, the growth plate, then you can actually stunt the growth or do permanent damage to that person's leg. It may not heal up right. Something to think about whenever you're down there shoving IOs and chicken bones. Which everybody loves doing, right? All right, big one. Tendons connect skeletal muscle to bone. Tendons connect muscle to bone. Tendons connect muscle to bone. Okay. Ligaments connect bone to bone. Ligaments connect bone to bone. So it says here, bone density decreases after the age of 35, which that's depressing, because I'm 37. So my bone density is already decreasing. I'm weaker already. I feel it too. Leads to loss of height and produces change in facial structure. I think fat produced facial structure in my face more than bone did. I'll blame it on bone. All right, pathophys. Sports injuries account for a significant number of musculoskeletal injuries, as you can figure. So among children, intentional trauma or abuse is a common cause of fractures. And then if you have a fracture, if you get a fracture that's due to medical conditions, that's called a pathologic fracture because your bone has become abnormally weak because of the illness. It's called a pathologic fracture. You can see here a high velocity injury typically shatters the bone and causes extensive soft tissue damage as well. And then forces may be transmitted along the length of a bone or through several bones in a series. So if you have something hit you on the wrist while you have an extended arm, you could have radius or ulna injuries or a humerus injury or something like that because it bam, 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 bam. You know, kind of like the what do you call that little device that I forget what you call it. It's got the kinetic balls, the kinetic spheres or whatever you call them, kinetic bearings. It's the tap. It does the tapping thing back and forth. I don't. We'll talk about it. So you want to immediately identify the point of contact and the mechanism of injury to decrease the chance of overlooking any associated injuries that have to do with some of these fractures. All right. So some injuries are commonly encountered because of the way the causative forces are transmitted. If you look in your book on table 33-1, there should be a table in there for that as well. So there's some nasty fractures there. You got some open fractures and as well as closed fractures. So a fracture is just, it's simplest, it's a break in the continuity of a bone. So fractures are either open or closed. You can see them there. In a closed fracture, skin remains intact. Open fracture, skin does not remain intact. It can come open, which can allow blood to escape as well. So blood loss can exceed 1 liter before enough pressure develops to tamponade the bleeding. Okay. So 1 liter, it's a lot of blood. So when you're treating these patients with possible fractures or dislocations, you need to determine whether the overlying skin is damaged or not, and then treat the injury that breaks the skin as a possible open fracture. So a non-displaced fracture is a simple crack of the bone that may be difficult to distinguish from a sprain or even a simple contusion also. So as medical personnel, we may actually use some of these terms. Transverse, oblique, spiral, comminuted, green stick, incomplete, pathologic, and epiphyseal. So signs and symptoms of fracture, you see their deformity, shortening, and then visual inspection, swelling at the site. You see there's some pretty significant angulation there in the picture. So as the blood infiltrates the tissue around the broken bone, the ends bruising will become apparent. There'll be bruising, things like that. So it's going to be associated with, like I said, ecchymosis around the surrounding tissues.
Hey Chase, I'm here. Sorry.
I see you.
Call AMR.
Trust me, we got 138 slides. We're on slide 33. It'll be okay.
Dude,
Yeah.
cruising the coast.
What about it?
It took us almost an hour to get to somebody that was never there, and then an hour just to get back.
Yeah,
Yeah.
I haven't even been in that area. I haven't looked at any of the cars or anything else. I'll go down there once during the week and just to take one look. Because I'm a car person, but I just don't have time. But I'll go down there once. I'll do a run there and back, and then I'll wrap it up from there. But yeah, it's terrible. So we try to make sure that all our shopping is done the week before and everything else, so that we don't have to get out. We're not people when it comes to those crowds. Anyway, there's a whole bunch of crowds. Now, generally, cruising the coast does come with some pretty, and when I say gnarly, I don't mean that. I don't mean gnarly like as in cool or anything else. Man, I've got to get a better chair. Cool or anything like that, but like gnarly, bad accidents that happen. We worked a few.
We got paged to. Oh, go ahead.
No, well, we worked a few. Like we worked one a while back that right there at Cowan Lorraine, they were coming around a corner and the door flew open. The guy fell out of the vehicle. The vehicle didn't have, I believe it didn't have seatbelts. It was an older vehicle, but the door come open. The guy rolled out, and his friend or family member or whatever that was in the vehicle behind him ran over him. Boom. And I mean, it gets some pretty bad calls out there during that. Go ahead.
We got paged to 4 different wrecks at one time. One truck did.
Oh yeah. Well, I mean, when you only got 4 trucks on the weekend.
Yeah, right.
You're gonna get paid somewhere. All right. So lock joint is difficult and pain to move, and an open fracture exposed bone may be in the wound. All right, so I went to a call, a late night call for a possible or a foot pain. It came out as foot pain. Okay. So I get in the battalion truck because the guy that was supposed to go to this call did not wake up. Go figure, fireman. I get all the way there, and when I go into the house, I see these circles. I see these circles all around the house. All right, and it's all over the floor. these perfectly round circles. And they're going all around the room. And I follow them all the way into the back bedroom. All right. So I walk into the back bedroom, and there's the patient lying in the bed, and she's saying, my foot hurts. My foot hurts. And I look, and this is exactly what I saw right here. So she was sitting in a chair. Her foot fell asleep. She's an older lady, a bigger older lady. Her foot fell asleep, or her leg fell asleep, and she stood up to go ahead and walk it off. And when she did, her foot broke over, and she had an open fracture. And then she thought that she had maybe sprained it because she couldn't see it. She couldn't see it. So she tried to walk it off. And what she was doing is this is what was causing the circles in the carpet and on the floor all the way to her back bedroom. That. Perfect circles all the way through there. It's pretty nuts. We ended up, I gave her some narcotics. I did do that. I gave her a little bit of narcotics and put her on a scoop stretcher, and then we got her outside. Yeah, she was hurting. What does spotlight do? Oh, I guess that's what spotlight does. I guess that's a fancy term for laser. All right. But yeah, that was a pretty interesting call. All right, dislocations. You can see that there. So the bone is displaced. It's not broken, but it's displaced. So the partial dislocation of a bone is called a subluxation. Subluxation. A dislocation that does not spontaneously reduce is a pretty serious problem. So some signs and symptoms, you can see them there. Marked deformity. Locked joint, which would be like the virtually complete loss of normal joint motion. We call that locked joint. Good stuff for your documentation. So as you can see here, it is considered an urgent injury because of a neurovascular compromise. Sprains. We're not going to get too far into these because we should know about sprains. Strains. We should know about strains. Achilles tendon rupture. All right. Athletes older than 30 years in start and stop sports. There you go. My Achilles would be in danger. So my bone density is low and my Achilles is in danger. This is sad. Amputations. So hemorrhage can hemorrhage from complete or incomplete amputations can be severe enough to be life-threatening. I would hope that you would know that. We just got to make sure that we're those life threats first. This looks bad. This does look terribly bad, but pay attention to the life threats. Okay. That's not going to kill somebody. The bleeding might, but missing a leg ain't going to kill somebody. Infection might. So attempts to splint and work to stabilize a patient's the patient condition are very important. Like I said before, do not become distracted by visually impressive injuries. Don't do it. Maintain a high index suspicion for other types of injuries when you're looking at these injuries. So golden hour, as you can see, it's not only for maintaining life, but also preserving limbs. So that golden hour, platinum 10, golden hour. So, and that's 1 hour from the time of the incident to the time that they hit the surgical room. Cold steel, we would call that. What is this? McAfee's wanting to fix my computer, I guess. All right, so we're not going to go through these surveys. We should know these, most definitely. So the 6 Ps of a musculoskeletal assessment. Does anybody know them? So the first one's going to be pain. Second one's going to be paralysis. The third one's going to be paresthesis.
Can you refresh my memory on what that is?
Paresthesis. Who wants to tell? Who knows? Give somebody a chance. So paresthesis, the way I always know it, and since it's part of your musculoskeletal, is like when you have the tingleness, or pins and needles. I think that's the best way to describe pins. You feel like you got pins and needles going on.
That's right. I kind of felt like that's what it was. Sorry.
Nope. All right, the next one is going to be pulselessness. Next, you're going to have pallor. And then pressure. My awesome writing. All right. You also want to make sure you evaluate the circulation, your PMS, right? Pulse, motor, and sensory. And then evaluate the joint below and above the site as well. All right. Inspect for those signs on your secondary assessment. So palpation of the pelvis. How do we palpate the pelvis? How do we check for crepitus in the pelvis? Does anybody remember? Purr. Yeah. All right. Yep. So you're going to push down. So if you got somebody that's all right. This guy's got a very long torso. If they're laying down, you'll push down first on both sides. On both sides. Down first, and then you'll push in towards the medial. So down first, then in. Down. What we don't do anymore is the pelvic rock. We don't do that anymore. The pelvic rock was where you held it and then you back and forth. So for somebody that's been an EMT for a while, like Ty, he was probably taught pelvic rock when he first got into EMT. I was taught pelvic rock. We don't do that anymore. Now we push down and then in. And if they go, or you feel crepitus, stop. So how do we fix? How do we mitigate that pelvic injury? What is it? What is something that we'll use? A sheet? Yeah. But what's a tool that we're hoping to have? Pelvic binder. That's right. Pelvic binder looks like a big weight belt or something like that, right? And we put it on there, and hopefully once we put, why does it do that? Why are you doing that to me? I clicked you. Could you use one if that's all you had is a KED? Could you use one if all you had is it? You talking about could I? No, no. So could you use it? I'm sure creatively there's something you could. The only problem with the KED is whenever you strap it down in the around the legs, what does that do? It pulls, right? It pulls it. It doesn't do a whole lot of squeezing, and that's what you want to do. You want to have a belt. So that's why we say a sheet or something like that. I'm sure if you get creative, there's a lot of things you can do if you get creative. I'm not saying you're wrong. I'm saying it's not optimal. How's that? I'm not going to say you're wrong. I'm just saying it's not optimal. If you could get a sheet or something like that, and all you got to do is tie it overhand knots, tie it tight, and then do it again. When did they become popular? I don't know, probably battlefield medicine, Afghanistan and Iraq, probably. Honestly, that's where most things, as far as trauma, most things as far as trauma comes from battlefield medicine. I've used one before. I used one with AMR before. It's probably the only one they bought. But yeah, sheet, tape, what have you. Keep it together. All right, reassessments. We know those. Be alert for signs of internal bleeding. There's a skill drill in your book, 33-2. So 20 mils per kg. 20 mils per kg when you're administering fluids to these patients. So cold packs are good for decreasing pain and swelling. It decreases the release of inflammatory mediators as well as what cold packs do. It causes vasoconstriction in the blood vessels in that region. And heat therapy, it should be avoided in the first 48 to 72 hours. This is for fractures and stuff like that. So in the first 48 to 72 hours, we want to do that. Yeah, like I said, you can. There's anything you do, be creative. I just don't think they're optimal for that. Just like I don't think a sheet is optimal, but I know I'm going to use a sheet. I personally will use a sheet before a KED. Why? Because it's faster. It's going to take me less time. That's me personally. Now, if you get to where, no, nobody thought you were stupid. Well, I didn't think you were stupid. I could see how it can be done, but I wouldn't consider it my first choice. But I tell you what, too, Mr. Wade, I tell you what, too, and it's good that you bring stuff up like that, and I'm glad you put that on there, because a while back, I got laughed at, too, over some procedures that I was doing, passive oxygenation, and I had gotten it out of a GEMS catalog, passive oxygenation, before dropping tubes, and how it raises your chances for a good tube. It raises you're oxygenating the brain. You're keeping the brain oxygenated while you're trying to get ready and everything else. And people are telling me like, that's crazy. You're wasting oxygen. How now that was stupid. That was stupid. You're wasting oxygen. That's stupid. So passive oxygenation, if you ever get a chance to look it up. When it first came out, I had read it in a magazine article and started practicing it. And I did it on every intubation. And we started noticing that the success rate of our intubations, or the success rate of our, not so much the intubations, but of our cardiac arrest were coming up. And in our capnography, that's where we were able to see it, in capnography, between the patients that weren't getting it and what their capnography was upon getting them intubated, and then patients that were getting passive oxygenation and what the capnography was once we got them intubated. And it was amazing. And from then on, everybody started doing passive oxygenation. I don't know if people do it anymore. There's a whole bunch of pneumatics now for AMR. I don't know if people passed on that knowledge. That passive oxygenation, if you ever get a chance to look it up, is fantastic. And it's something that if you're riding with a medic and you have a cardiac arrest, you come in, you may try to hook it up. All it is a nasal cannula. You put a nasal cannula on the unresponsive patient, put that nasal cannula on there and crank that bastard up to 15 FPM, as high as you can go, and let it just spray O2 into that patient while they prepare, because they're slow and fumble around, while they prepare for that patient to get an ET tube, or while they're trying to get that tube. It's out of your way. Why wouldn't you? Passive oxygenation, and then taking your suction and putting it underneath the patient's shoulder, or putting it in their underarm, right under their underarm. I've done that too. That way it's ready. And making sure all you're in preparation too. Don't just grab your bag, roll with that. Same thing with IVs. Don't just grab your bag and think you're going to grab one thing at a time as you're doing the IV. Who knows the 6 Ps? Anybody know the 6 Ps? Proper preparation prevents piss poor performance. Proper preparation prevents piss poor performance. 6 Ps. There's a lot of Ps. It's a lot of PS. All right, splinting. So these are the ones that, splinting, you have a device or anything like that. There's directions on the device, right? But when you're really using your noodle, and it shouldn't even be using your noodle, it should come second nature, is whenever you start doing things like this. That is when you're thinking. That's fast. That's fast. That's fast and easy. All right. Can we take a few minutes? Yeah. Let's take a 10-minute break. That sounds fantastic, Leanne. Because I'm gonna grab a coffee while that's going on. Talk amongst yourselves.
Next time you look at your budget and you see subscription fees for your PDF software, remember this: you've got a choice. My company was using expense.
All right. I'll be back in a little bit. In 10 minutes, approximately. All right, we're back. I got a coffee. It took me a minute to make it. And it's because my youngin' thought it would be funny to run up behind me and scare me. I had to call him the ambulance. Oh, this morning, it was funny. I needed or it was yesterday or this morning. It may have been yesterday. I don't know. One of these days. Someday I took a shower. So it had to be within recent for my monthly shower. But I asked him, I said, hey, I forgot my towel. I said, hey, go get me a towel. Go get me a towel. And so, you do the arm sticking out of the door thing, stick your arm outside the door and wait for somebody to hand you a towel. And he says, here, this is all you need. And he hands me this little baby rag like this and puts it in my hand. That's all you need. And then throws that in my hand and then runs off. I was like, boy, go get me a towel before I lose my mind. He thinks he's funny. He think him is funny. All right. Types of splints. I gotta turn that fan down. It's gonna get cold in here. Fan was kicking. It was starting to get cold. Can y'all hear me? Make sure I'm good to go. All right, and away we go. So see here, the best way to stabilize multiple fractures in a critical condition is to splint the axial skeleton using a long board and straps or an alternative device. Got to protect against spinal injury. And this also, it reduces the movement of the injured extremities by securing them to the board. Okay. So in a hurry, that may be something you may have to consider. We've had to do things like this on bad car wrecks, bad femur fractures and everything while we were trying to get them up an embankment. We didn't have the hair fracture or hair fracture device or anything like that to get everything fixed up like we needed to. So we used the backboard until such time that we could get to a place where we could operate a little bit better. So some of the principles of splinting: you want to remove the clothing from the area of any suspected fracture, all right, or dislocation, and that way you can inspect everything using DCAT BTLS, right? So you want to be able to inspect everything. Assess and record the patient's neurovascular status distal to the site of the injury. Okay, distal, further away, right? And when I say record, you need to make sure you have the documentation because you're trending. You want to make sure that you put that in your documentation, you record that down because later on it may change. They may start some tingling. They may not be able to feel it. Some of the stuff that we're looking out for is things like compartment syndrome, things like that. That's what we're looking for. And then cover all wounds with dry sterile dressing before you start splinting. So don't move the patient before splinting the extremity unless there's an immediate hazard to the patient or to yourself. So don't move that patient until you're ready to start splinting, unless there's an immediate hazard. Okay. So if you're splinting fractures, you want to make sure that you should immobilize the bone ends and the two adjacent joints. The bone ends and the two adjacent joints. If you're working with dislocations, then the splint must extend along the entire length of the bone, above and also the entire length of the bone below the dislocated joint. So longer, right? So to manually support the injured site, you're going to place your hands above and below the site, the injury site. So if a long bone is severely, if you have a long bone that's severely angulated and there's no pulse that's present in the extremity or distally when you're doing your checks, you want to gently apply that longitudinal traction, right? And also to try to get that pulse back, to try and get that traction in there. And maybe you can, help fix that angulation. Maybe you can help get that circulation back, because without that circulation, a lot of issues can come across. But you don't want to attempt to straighten a fracture involving joints without first obtaining some sort of med direction, right? So call your medical direction and ask them if that's something that's okay, or if it's in your protocol, you may be able to do it then as well. So if you're trying to pull traction and the patient is reporting severe pain, or there's a significant resistance to movement, discontinue applying the traction, splint the joint in place, and move on, because we don't know what's going on at that point. If they're not getting any relief from the traction, then something else may be going on. Cease the operation, fix up what you can, move on. So also you want to, if you have that type of incident, possibly, and also, or if you're splinting or what have you, you're splinting and covering, make sure that you leave the fingers and toes out of the splint, so you can check those. You can check your PMSs, right? If it's possible to apply cold packs to that and elevate the splinted limb, it's going to help minimize the swelling. When in doubt, splint it. So you want to be aware of the hazards associated with improper application of the splints. There's a list of them right there. This is the one that gets people most of the time, is delay in transport with a life-threatening injury. People get so focused on doing other things on scene that, giving somebody diesel is very important. You got to remember that giving somebody diesels, it's fairly important. Good Lord, important. Traction splints. Yeah. So traction splints. The application of inline traction is the act of pulling on the body structure in the direction of its normal alignment. Okay. So, and this is supposed to help line the limb up as well as decrease pain. And it could possibly, there's other things that can be done is a reducing blood loss, so on and so forth. The problem that you have is that if you try to pull traction excessively, all right, I've seen people get on these traction splints and pull and pull and pull, and now they're almost longer than what the original leg was, or whatever they're doing. That's not what we're trying to do. We're not trying to pull it apart. We're just trying to reduce it. Okay. We're trying to reduce it down, because what happens is that bone breaks, and whenever that bone breaks, that muscle automatically tightens up, right? And when that happens, it gets shorter. Okay. All right. It gets shorter. And then what you're trying to do by traction is you're going to be on this end, you're going to be on this end, and you're just pulling. And what you're hoping to do is just reduce it back. Okay. You're not going to fix anything. You're just reducing it down. You're trying to bring take some of that pain away. But if you get to pulling, and now you're like this, that's an issue. You're going to cause issues. So excessive traction, it's harmful. And like it says here, do not attempt to reduce the fracture or force all the bone fragments back into alignment. That's not what you're trying to do. You're just trying to reduce it down. If it gets back into alignment, whatever, but that's not what the goal is. The goal is to ease pain. Yep. So all you're doing is stabilizing. Stabilize and prevent excessive movement. The least amount of force necessary. That's the goal. The least amount of force necessary. So it also helps if a second person can support the injured limb directly under the side of the fracture. If they can support it directly under while they're pulling traction, or while you're pulling traction, it may help. So we're not going to use traction. Also, thanks for bringing this up. There's times that we're not going to use it, and that's when you have a lower leg injury. If you have a lower leg injury, you're not going to utilize traction. Or if you have a joint injury, you're not going to utilize traction either. And then also, this should go without saying, but traction splints aren't suitable for use with upper extremities either. So really, femur fractures, right? Femur fractures. So as we said in the last slide, following conditions, you're not going to use a traction splint. Injuries closer involving the knee, injuries to the pelvis, partial amputations or avulsions with bone separation, lower leg, foot, and ankle injuries. Don't want to do it. Don't do it. It's not good. All right, hair traction splint. If you look in your book, skill drill 33-3 shows you how to use a hair traction splint. You might see one. A Sager splint. You might see one of those too. There's also a skill drill for that as well. So it says here it takes 2 EMTs to apply a rigid splint. Okay. It takes, according to the book, it takes 2 EMTs to apply a rigid splint. All right. As you're reading here, there are 2 situations in which you must splint the limb in the position of deformity. When the deformity is severe, you need to splint it as is. And then when you encounter resistance or extreme pain when you try to apply traction, that's when you need to do it as well, when you need to splint the limb in the position that it is. And don't get all crazy trying to apply traction. If a couple times you can't get it, go. If you can't, and I would usually say if you can't get it after the first time, because it's pretty traumatic. If you can't get it after the first time, go, move on. Because what happens is you start to aggravate that area. And if you start to aggravate that area, muscles tighten up and everything else, and you could cause more damage than what you would have done if you'd have just splinted it in the position as is. Pneumatic splints, you put it on there, you put air in it. You inflate it up once you get it in there, and it should do that. Don't use it with open fractures. It's like a balloon. Don't use it with an open fracture. It might pop it. Okay. And then if there's any open wounds that are there, make sure you cover them up with a dry sterile dressing beforehand. PASGs, contraindicated for treatment of shock. We don't use them for shock. Ty, you should remember that. We used to use junk like that for shock. Don't use, here's some contraindications as well. Contraindicated is a good documentation word. Contraindication or contraindicated. So PASGs aren't to be removed in the field. They're to be removed in the hospital. Make sure that when you come in there, that you show them how to undo the thing, how to take it down. Because if not, what do you think that they're going to do in the ER when they come across this expensive, reusable PASG? That's right, Ty. They're going to cut those suckers off. They're going to cut it off, and that's going to be it. Your expensive little toy is gone. formable splints, pillow splints, structural aluminum malleable splints, or your SAM splint. I think I showed y'all one of those the other day. Vacuum splints get fit around a deformed limb. I've never used a vacuum splint. Sling and swath. Pelvic binder. Those are good stuff. For transportation, I do like this one. I do like this one. Very few, if any, injuries justify the use of excessive speed during transport. What good are you if you die trying to get a patient to the hospital? We talk about speeding all the time in the fire service. We have here lately, especially because you see it a lot. Firefighters hauling butt everywhere they go. Cops hauling butt everywhere they go. Things like that. So there was a lot of times going to calls. I wouldn't even turn my lights and sirens on to go to a call. And reason being is that the difference between me hauling butt to get there and the difference between me being safe in getting there was literally, I mean, less than a minute most times. At the most, I could have shaved a minute off, but that's a rarity. At most times, just driving there in a normal sense, I got there relatively about the same time as I would have if I were rushing around. Okay. So we found that. And if you don't believe me, test it. But we're also not running into a lot of red lights and stuff like that too, that we can go through. Out in the county, there's no red lights really. So it's just roads. Think about that next time you reach down to hit that siren or anything else. Now I get it. Depending on who your service is, they want you to go priority 1, priority 2, or what have you, code 3, or whatever your agency calls it. But there's not much difference in speeding your rear end to get there and taking your time. Yeah, well, I mean, you're definitely going to have heavy traffic in New Orleans. Also in New Orleans, if you've ridden in a truck with lights and sirens on, what do people do? Yes. Yeah, Tampa, yeah. It was literally less than a minute. And that's in Tampa. They slam on the brakes. They get in your way. That's right. They slam on the brakes. They get in their way. They don't care to move out of your way. They're not going to do it. Yeah, a lot of times they do. So, I mean, sometimes just getting there, just by normal driving, getting around them or whatever you need to do, then you'll get there in less than a minute, difference of less than a minute. And you're not all frazzled by the time you got there. And everybody arrived safely. Complications of musculoskeletal injuries. There's really a couple that I wanted to talk about. I have to see the slides whenever they come up. my slides are here, and I changed it. My slides used to be on this screen here, and my camera used to be over here. Now my camera's over here, and my slides are over here. So I'm trying to look at the camera and all that mess at the same time while I'm talking. So it takes me a second. Yeah. Did you ever work with Jessie Mae? Ty? Well, she's married now with kids. Not Miller's Grover anymore. She still worked for AAA? She had a pretty bad wreck some years ago that rolled one over. But I mean that she did. Yeah, she did. After running a long shift, apparently. But yeah, you got to be careful running around out there. All right, compartment syndrome. This is one of the ones I want to talk about. So compartment syndrome. The fascia confines muscles to an enclosed space or compartment. Compartment syndrome is one of the most devastating consequences of musculoskeletal injury. So the longer this situation persists, the greater the chance for tissue necrosis to happen. So both external and internal factors can lead to the development of compartment syndrome. You have open fractures that have a higher risk of compartment syndrome because they're typically associated with higher energy injuries. And compartment syndrome usually develops within 6 to 12 hours of an injury. It's characterized by severe pain that's localized in the involved compartment. The skin pallor, it may be apparent, as well as paresthesis. Remember pins and needles, paresthesis, pins and needles, skin pallor, pale. Another late sign of compartment syndrome also is absence of distal pulses in the affected extremity. That's with your trending, not so much if it's angulated, you reach down there, feel a pulse. Nope, I don't feel a pulse. It's you had a pulse at one point and now you don't have a pulse because of the swelling. You may end up in a compartment syndrome type deal. So if a patient has a fracture below the elbow or the knee, ask about the following. And that's where you see it there: extreme pain, decreased pain sensation, pain on stretching of affected muscles, decreased strength. So the goal of your pre-hospital care is to deliver a patient to the emergency facility before the extremity is pulseless. So rip and roar. Put them in 4, rip and roar. Get them to the hospital. Give them diesel. So there's your management. One big thing to remove is rings on hands, rings. I guess on toes too now. People got toe rings and stuff. So compartment syndrome, it has to be managed surgically. So get them to the hospital. Be your best chance. And look, it's one of the few here that you can do nitrous oxide. Right. Crush syndrome. That's another one. And we've talked about one of these words. So the rhabdomyolysis. So myoglobin being the harmful product that they're talking about. So it says here, after a muscle is compressed for 4 to 6 hours, so the muscle begins to, it can happen sooner than that. And there's different ways that you can find it or that you can tell if it's going on. But what happens is the muscles begin to die and they release their contents into the localized vasculature. So the myoglobin, you have that buildup of lactic acid, then it turns into myoglobin. That myoglobin gets into the vasculature, and if it's released and it gets to the heart, it can actually stop your heart. It can cause a cardiac arrest. Rhabdomyolysis can, or cause some deadly arrhythmias. So one thing is like one of the important things is you want to give a bolus of crystalloid solutions. And don't apply anything compressive such as a PASG or anything like that. Thromboembolic disease. So DVTs. You can see there. Then that's a no-go area. So if a DVT dislodges, that can actually cause a pulmonary embolism. Which in turn can cause death. Right. Well, for that, just go with look for your signs and symptoms. If your patient gets to where they're panicking, they're, impending sense of doom, they can't breathe correctly, things like that. Most of the time, very anxious. They all of a sudden get very anxious, impending sense of doom. They can't breathe. You see their sac starting to get a little lower. Man, you need to think PE. They're starting to have chest pain or something like that. You need to start thinking PE, depending on what it is, or due to DVTs. So some signs that you're looking for DVTs is disproportionate swelling of the extremity, discomfort in the extremity if it worsens, warmth and erythema of the extremity. Because when it does release, you could have yourself a PE or a pulmonary embolism on your hands. So here's your signs of a pulmonary embolism. Pay attention to these signs. This could mean the difference between saving somebody's life and jacking this up, which I have seen firsthand. Somebody jack this kind of call up. Injuries to the scapula. On this bird-chested young man here, mainly what you're looking for you see this bruise. That's what it's trying to show you. So young kids, they often report pain throughout the entire arm, and they're unwilling to use any part of their injured limb. So that's kind of how you can find that in a kid. So fractures of the scapula. So you want to check for hemo or pneumothorax or hemopneumothorax. Make sure you provide that supplemental oxygen and prompt transport for that patient if they're especially if they're having respiratory difficulty. So it's going to be the associated chest injury, not the fractured scapula itself, that pose the greatest threat of long-term disability. So the associated chest injury possible, that's going to be the greatest threat there. So the acromioclavicular joint, or AC joint. So most often it's called an AC separation. The distal end of the clavicle is usually what's sticking out. So you can see that here. It's that distal end of the clavicle. So a sling and swath, I mean. When you do the knot, when you tie the knot there, see how he's got the knot? Oh, Lordy. No. There we go. What am I doing here? What am I doing with my life? All right, so a lot of times this gets missed. Make sure that the knot is not on the neck, on the spine. Try to keep it off the cervical spine. So put the knot off to the side. A lot of people miss that. And then also making sure that this forms a 90. Okay. Make sure you leave the fingers exposed as well. All right, glenohumeral joint. Shoulder dislocations. We've seen quite a bit of those. Everybody should know how to deal with a dislocated shoulder. We'll be doing some sling and swath stuff this weekend too. Fractures of the humerus. Sling and swath with a little bit of modification there. So look out for compartment syndrome and in the forearm if children, a lot of times children with those fractures. Elbow injuries. I say there's going to be a lot of stuff in here that I skip over. Where do you think this break is? Is it here? Is it here? Not so much here. Not so much here. Maybe here. There's something going on. All right. All right, Coley's fractures. We talked about this, children and the growth plate. Any breaks in the growth plate or anything like that you can have long-term consequences. Don't attempt to pop a dislocated finger. And then if you do have something that's amputated, you know, wrap in a dry or moist sterile dressing, depending on the local protocol, and bring it with you. Bring them digits. Fractures of the pelvis, we went over that. How it can cause massive hemorrhaging. All right, and this is a lateral compression type injury. pelvic ring disruptions. So the pelvic ring. Open book fracture. We talked about those. I would draw it, but I'm bad at drawing it. Remember, you take the open book. I thought my camera was here still. Take the open book. Your pelvis is usually like this, right? You have an open book fracture. It lays open. A lot of times you can see, because you'll see these patients from a distance, because their legs will be pointed like this. They'll be pointed out like that. They'll be laid out. I definitely can't draw. All right, vertical shear. Oh. So shortening of the limbs, that's what you're looking for there. Possible massive hemorrhaging. If that happens, you can lose almost the entire contents of your blood inside your pelvis. So something definitely you want to make sure you're not moving these patients all over the place. You know, that's where you may get into your scoop stretchers and things like that to keep from having to move those patients. Even rolling them could be an issue. That's why I talk about scoop stretchers. Straddle fractures. All right. So simple tenderness on firm compression and palpation. So assess for that tenderness. See how he's pushing in and pushing down. That's where he's having those issues. Large bore catheter, IV access by a large bore catheter. That's where you want to do it. All right, we're not going to get into dislocations too much. We'll talk about those during drill or during boot camp. So fractures to the proximal femur rarely involve the hip joint, the intertrochanteric, which is the middle region, or across the proximal shaft of the femur, the subtrochanteric fractures, where the trochanter is at. Greater trochanter. You see a lot of your elderly patients may have something that goes with that. A lot of times a humeral head gets broken right there. We've talked about this. We've talked about that. We've talked about knee injuries, how you're not going to pull traction on those, right? Patella dislocations. Look one of those up if you ever get a chance. Patella dislocations. Knee just giving out. So they can have a knee dislocation, typically report a pain in the knee or report that their knee just gave out. That could be a dislocation. As you can see there, we talked about it earlier, making sure that you have a long, you're trying to capture everything in this instance. Capturing everything. There's a knee injury there. That looks pretty rough. Dislocation of the patella. All right, we've talked about those. Ankle injuries, we talked about those. Sprains. Foot injuries. Hey. Whoop. So we knocked that out. Wasn't a lot. A lot of it was stuff like a lot of it's stuff that you already know as an EMT or things that you've already dealt with. A lot of it also you'll get during your boot camp when we talk about sling and slough, when we talk about splinting things, stuff like that. We'll talk about a lot of this. So 138 slides, and we were able to knock it out in a very good amount of time. Also, it's going to give me time to get that module test in there. Remember, you have time to study. Okay, you have time to study for that module test. So let's make it happen. Make sure we get it done. So your code for tonight's test is going to be 3216, and that's also the code for that you'll put in there for your attendance deal. So 3216 will be your code. All right, I'm going to go ahead and stop recording. Maybe.